Hi, my name is Erin Parkinson. I'm a nurse practitioner with the Transplant Institute at Tampa General Medical Group. I work in general hepatology and transplant hepatology, both inpatient and outpatient. And we're here today to talk about the diagnostic workup of MASLD or MASH. So what tests do we order and when do we get them? When I see a patient come into the office, there's a lot of things that, go through my mind. And what am I suspecting just based on glancing at their chart, looking at the patient themselves? But what would I need to see in order to suspect MASH in my patient? First of all, I'm going to be looking at their medical history. So, what metabolic risk factors do they have? Are they obese? Are they diabetic? Do they have high blood pressure? Do they have sleep apnea? Those are the types of things that'll lead me down that road of thinking MASLD or MASH. And then I'm looking at what workup has been done. So, abdominal ultrasound. It can be useful, particularly in the beginning when you want to identify steatosis. So for a diagnosis of MASLD, we want to see steatosis on imaging with cardiometabolic risk factors. So an ultrasound is helpful for that. You can see the increased echogenicity and the steatosis. Beyond that, it's not really that helpful because it doesn't tell me anything about stages of fibrosis. I can't tell, stage 1 versus stage 2 versus stage 3 fibrosis on an ultrasound. If someone is obviously cirrhotic, if they have a nodular atrophic liver, that will show up on ultrasound. Maybe they'll have some suggestions of advanced liver disease. They might have a big spleen. Splenomegaly can be one of the very first things that we see in advanced liver disease prior to the liver actually looking abnormal on ultrasound. If you have a Doppler and it picks up, you might see a dilated portal vein. That can be helpful. But otherwise, that's not my staging test that I need. They come into the office, so I'm suspecting MASH or MASLD based on risk factors, based on steatosis on imaging. What else am I going to do? Well, I want to rule out other causes of liver disease. So I need to do my chronic liver disease workup. That means testing for viral hepatitis. It means testing for autoimmune disease. We can do our initial iron studies to rule out hereditary hemochromatosis. I usually do that alpha-1 antitrypsin. So we're ruling out other reasons that these people could have liver disease, and they could have, multiple causes of their liver disease. So we have our imaging, our chronic liver workup, our history of the patient, and our physical exam. What next? Well, for their history, the other thing I'm going to want to know is alcohol intake. A fatty liver on imaging is a fatty liver. It'll look that way whether it's from alcohol or whether it's from their metabolic risk factors. So we need to know quantity, and that's always hard to hash out from people, right? Because it'll be like, oh, I just socially drink. Well, what is social drinking to you? Are you socially active, with your friends every night? And that means you're having 2 to 3 drinks on a nightly basis. That's a little different than someone who has a drink on their birthday and at Christmas. So we need to quantify the amount of alcohol intake. And, they always, in most of the guidelines, they have it by grams of alcohol, which I find funny since no one measures their drinks in grams of alcohol. But, it's about 20 to 30 grams is about 1 to 2 servings of alcohol, whether that's a glass of wine or a beer. So once we have all of that information, say we can make our diagnosis of MASLD. So fatty liver, cardiometabolic risk factors, no other reason for their liver disease, and no excessive alcohol intake. Now we need to risk stratify. So who do I worry about and who do I not worry about? Not everyone that has fatty liver will develop fibrosis or significant liver disease. So the initial test that I would do is a FIB4, and that's just your calculation based on the liver enzymes, platelets, and age. And there are algorithms available now that can help walk you down the pathways. But essentially, we're looking for low-risk patients, so those that are unlikely to have significant liver disease. We might get an indeterminate result, so we're not really sure, or a high likelihood of having advanced or significant liver disease. And, how aggressive am I going to be depending on those results? Ideally, I'm going to have access to a FibroScan as well. The FIB4 is a good initial screening test. I think it's helpful in primary care, maybe in endocrinology. But if you come to a, liver office, or if you have access to it in your community, obtaining a FibroScan is really important so that we can determine, how much fibrosis a patient actually has. And once we get that FibroScan, now what? So let's say the FibroScan comes back showing stage 2 fibrosis. How much urgency is there for this patient? Well, if it's a 25-year-old that has MASLD and stage 2 fibrosis, I'm much more aggressive than someone who's 70 and has stage 2 fibrosis with MASLD. So, the age of the patient is also very important. Why would I order, say, something else, maybe additional testing beyond a FibroScan? If I'm getting really conflicting results that just don't make sense, then I'm going to obtain additional testing. The ELF score is something that you can do. It's a laboratory-based test that's supposed to tell you about fibrosis. I don't personally use it in practice, but it is included in the guidelines, and it's something that can be used for sure. Sometimes I'll obtain an MR elastography. So if I have conflicting results from, say, 2 different FibroScans or imaging versus what's showing up on a FibroScan, then I'll get an MR elastography to try to help clarify things. Now, if we go through this whole algorithm, we obtained our Fib4 and we also got a FibroScan, and the FibroScan is coming back saying stage 0 to 1, low risk. That's someone who can be reassessed in 2 to 3 years. That's someone who can be referred back to the primary care and, with recommendations for lifestyle modifications, for monitoring of their, liver enzymes, even though they're not always elevated, and to repeat the FibroScan in 2 to 3 years. If anything above that, so stage 2 or above, we would keep them in the hepatology office because we're going to, talk about other treatments that are available, and we're going to, watch these people more closely. Other testing, just to keep in mind, of course, if you have someone with advanced fibrosis or cirrhosis, then we want to be thinking about their HCC screening. So we need to be screening them for liver cancer every 6 months. That will also be really important to keep in mind and take into consideration. Other imaging tests, I don't really utilize other types of imaging unless I'm concerned about the advanced fibrosis or cirrhosis. Then I'll get a good quality, multi-phase contrasted study like a CT, 4-phase CT or an MR, just to, again, look at the morphology of the liver, but also screen for liver cancer. All right. Well, thank you so much for listening. If you have any questions, please don't hesitate to reach out.